Hello, everyone, and welcome. We're excited that so many of you could join us today for on the therapeutic applications of psilocybin. I'm Jason MacArthur, the events coordinator for the Public Programs Department of the California Institute of Integral Studies, a nonprofit university in San Francisco. As many of us are descendants of settlers, immigrants, or descendants of those forcefully brought to this continent, we, CIIS Public Programs, must recognize and never forget the university's building in San Francisco occupies traditional, unceded Ramaytush Ohlone lands. If you're interested in learning more about Native lands, languages, and territories, we encourage you to visit native-land.ca. Now, let me first introduce our presenters, Gisele Fernandes-Osterhold and Brian Anderson, and then we'll get right to the conversation. Gisele Fernandes-Osterhold is a licensed psychotherapist, associate professor at CIIS, mentor at the Center of Psychedelic Therapies and Research, and clinical supervisor at the SAGE Institute. Her clinical and academic work is trauma-informed, rooted in somatic, humanistic, and transpersonal psychologies, with a focus on social justice and embodied spirituality. Brian Anderson is assistant clinical professor in the UCSF Department of Psychiatry and Behavioral Sciences, and an attending psychiatrist in the Psychiatric Emergency Services at Zuckerberg San Francisco General Hospital. Over the last 15 years, he conducted both ethnographic and clinical research with people who use drugs, including ayahuasca-using religious groups in South America and crack cocaine and alcohol users in Mexico City. At UCSF, in 2018, he conducted a pilot study of psilocybin-assisted group psychotherapy for demoralization in older long-term AIDS surviving men. His research seeks to examine how people are both benefited and harmed by high-risk controlled substance use in clinical and community settings. And now, let me turn it over to Gisele and Brian.
Good evening, everybody. Good evening, Brian. It's so nice to be here with you. Welcome.
Thanks for having me, Gisele. It's great to see you.
Yeah, so our conversation today, we're talking about psychedelic mushrooms, and we know that they grow in many parts of the world, in North and South America, in Europe, in Asia, in Africa, in Australia, actually in all continents except Antarctica. And there are findings of prehistoric rock art offering a hypothesis that mushrooms were used in religious rituals 6,000 years ago. Psilocybin mushrooms have been used in ceremonies in Mexico and Central America as a sacrament for thousands of years. And it was first introduced to the United States here in the late 50s by Gordon Watson and his wife, Valentina, after they came back from Oaxaca, and it became news in local magazines. And today, as we're here to talk about the therapeutic use of psilocybin for the treatment of anxiety and depression. But before we get into the details of what the research shows and of your work in this field, how about we set the frame of our conversation by first clarifying the differences between magic mushrooms used in specific cultural and ceremonial contexts versus the psilocybin used in research here in the US.
Yeah, great. It is, I think, really important, as you already mentioned, to recognize that the use of psilocybin mushrooms has a long-standing tradition in a number of communities throughout the Americas and elsewhere. And that this really predates sort of the very initial knowledge that we have of this in biomedicine. So a lot of the clinical trials that we see today are building off of research that was initiated in the 1950s, 60s, and 70s. And even that medical research, initially took a lot of information from indigenous communities that have longstanding wisdom about how to use these as tools for spiritual healing and other purposes. So I think it's a really important framing, certainly for us to start with.
Mm-hmm. And also the way that the mushroom is prepared, right? So in these ceremonies, they would, many times cultivate the mushrooms and get them in nature and use it in a natural form. And in the research, when we are discussing here today, we're going to be talking about psilocybin-assisted psychotherapy. It's not exactly the mushroom that these communities used. Is that correct?
Yeah, exactly. So in the clinical trials that we're mostly going to be talking about today, the investigators have used just a pure synthetic version of psilocybin, which really is just one of the psychoactive compounds that you can find in psilocybe mushrooms. And so, yeah, this question does come up a lot. Do you ever give mushrooms to participants in research? I'm only aware of one study that actually happened in Brazil, maybe about 10 years ago, in a psychology department, where psilocybe mushrooms were harvested. They're chemically characterized, and they were given to healthy volunteer participants to assess the effects. But beyond that, all the other studies going back to the 50s and 60s was all pure synthetic psilocybin.
Mhm. Yeah, so the psilocybin and its related compounds are referred to as being hallucinogens because they promote a change in perception and an internal visionary experience. They're known as being psychedelic because it's mind manifesting. And they're also known as entheogens, becoming God or divine within. So these terms are often used interchangeably because they speak of the different dimensions of the magic mushrooms. Would you like to elaborate on the effects that psilocybin may produce on the mind, body, and soul when taken in high doses?
Sure. And you listed three sort of key terms that we see a lot in the medical literature: hallucinogen, psychedelic, and entheogen. I imagine that depending on the research setting and what people were volunteering for, that could certainly change the outcome that people would report. What are the effects, right? I think it's also really notable that the modern research with psilocybin starting in the 2000s, the first study that really kind of put on the map a lot of this research was not a clinical treatment study. It was actually assessing the mystical type and the spiritual type effects, right? As we know, the study out of Johns Hopkins by Roland Griffiths, Bill Richards, Bob Jesse, and that team, they specifically looked at what might be called sort of transcendent effects, sort of feeling outside of oneself, connected to the larger universe around you, beyond space and time. And at higher doses, this certainly is seen in a number of studies, effects like that. And yet, there's a number of different traditions that we can look at in the literature that look at lower doses as well, moderate doses, like is used in a lot of the studies today. But when we're talking about higher dose studies, you're right, there's these kind of entheogen-like effects, or what people are starting to associate more with this idea of a psychedelic mystical type effects are the sort of stepping outside of the self. We're looking at the core root of the word ecstasy, sort of being outside of self. These are the effects that I think we hear most about in the news today, and seem to be associated with actual therapeutic benefit when we're looking at treating patients in these trials.
Yeah, it's very interesting because if we go back to the 1960s in Boston and that famous Good Friday experiment, which was one of the first studies that scientifically evaluated the potential of psilocybin, right? It was conducted by Walter Pahnke and Timothy Leary and Richard Alpert were at Harvard at the time. And I think they actually lost their jobs there because of this, because they were overseeing the study. That study, would you want to talk about that a little bit and how it links to the current studies, on this idea that the mystical experiences are really key in effect?
Sure. Yeah, I mean, the controversy about how Timothy Leary and his colleagues ended up leaving Harvard is complex, and I'll leave that for someone else who maybe knows that better. I don't think it was because they particularly did the Good Friday experiment, but certainly some of the what happened after that, what was involved with their leaving the institution. But the Good Friday experiment was one of the studies that they conducted at Harvard, along with the Concord prison experiment and others, where they were examining with the tools that were available to psychology at the time, what are the outcomes of high dose psilocybin experiences? And what I think of as really notable about that study and really commendable is that they weren't just looking to see, is it a treatment? They were, and not just looking to see, does it cause psychosis, like a lot of other investigators were wondering about psychedelics at the time, but they wanted to assess, can psychedelics like psilocybin, when taken in a really supportive setting, amongst people with a predetermined set. So they were just working with seminarians or people who already have a spiritual and religious background. If given in a setting where they might be primed to have a mystical type experience, could they elicit or could they occasion what would be quantified with scales as being akin to the types of experiences that saints from the Judeo-Christian tradition had talked about in the sort of in older texts of being in touch with a higher being, leaving oneself in extreme states of bliss or deep knowledge. And they did find that high dose psilocybin led to those experiences more than people who had a control substance. And importantly, they also found that sometimes people had really challenging experiences with high dose psilocybin, and that didn't actually come out in the original papers, thanks to some of the research that Rick Doblin had done, and I think in the 90s, going back and evaluating what were the outcomes. It then came out later that some people had a very hard time with that, and so I think we need to, as we talk about all these studies, really keep in mind what might be really good sounding effects, transcending of self and having a state of bliss, and then also what are the challenging and hard parts about this work that we really need to be transparent about too.
Yeah, and we're gonna get there tonight. So, but before we go into the hard aspects of the work, so here we're establishing that, both from the research in the 60s and the research in the 2000s, like the ones you mentioned at Johns Hopkins, the investigation, if psilocybin is conducted in a setting that is safe and that there's enough preparation and integration, there are this possibility of mystical type of experiences, and that has paved the way to look into applications in the treatment of psychological suffering, especially related to cancer and end-of-life illnesses. And so here in the United States, we know of NYU and Johns Hopkins, University of Maryland, UCLA, UCSF. A lot of these studies are connected to palliative care and the treatment of anxiety in face of cancer diagnosis, and some other studies investigating the treatment of depression. So would you like to expand a little bit and talk about some of these studies, the overall research frame, discuss some of the therapeutic outcomes, and also bring in a little bit of your work and the research that you have been involved in?
Yeah, great. I mean, the applications of psychedelics like psilocybin in palliative care is something I think is a really rich area that I think our patients could really benefit from having more rigorous information available. As you said, there's been research on how to treat distress in, for instance, patients with cancer, going back to many decades. Some pioneering work also from Walter Pahnke and Bill Richards in Maryland in the 1960s and 70s, as well as Eric Cast using LSD, and Sidney Cohen really laid the groundwork for some foundational studies that came out, as you mentioned, Charlie Grobe's work in UCLA that came out in around 2010, soon followed by two studies at NYU and Johns Hopkins that were double-blind, randomized controlled trials comparing either psilocybin in its full dose combined with psychotherapy, comparing that to such a small dose of psilocybin that it shouldn't have an effect, as they did at Johns Hopkins, or an active control, like niacin. There were large effects that were seen in really sort of gold standard measures of depression, anxiety, And this has really, I think, opened up the field for more research, like the pilot study we did at UCSF. But the big picture that I keep on coming back to with this work is that even with a substance like an SSRI, something like fluoxetine or Prozac that we call an antidepressant, it may be good for depression, it may help, but it also probably helps some other things, anxiety and other conditions. And so just because psilocybin may help depression doesn't just mean that it's an antidepressant. And so as we've seen some initial really positive early findings of how psilocybin therapy can help mood and anxiety in cancer patients, it's also, I think, telling that these studies have found measures of death transcendence, change with high dose psilocybin. And there's anecdotal reports of patients find it easier to just open up and talk with their loved ones sometimes after these treatments. And so there's a lot of sort of interesting early data that we can follow to see how this might be possibly an important treatment to offer people towards the end of life.
Mm-hmm. It's my understanding from reviewing most of the research that the focus on palliative care that addresses the psychological, the existential, the spiritual distress experienced by the dying has tremendous positive outcomes with psilocybin, because it's described as the demoralization syndrome, right? That patients experience at the end of life, and they feel hopeless and helpless, and the meaninglessness. It's really an existential distress that is at the core of the suffering there in palliative care, and psilocybin then brings in this enhanced sense of existential and spiritual well-being that then it's looked at as a key factor in the improvement of a psychological and social functioning to deal with that distress. Now, when you're talking about depression, then there's other components there, such as the need for psychotherapy. And I can't help it but to remember this article that just came out now last month by the Imperial College of London that compares the use of antidepressant, I think Lexapro, with psilocybin. And do you want to mention something about that study?
Yeah, so the study you're referring to, the lead author was Robin Carhart-Harris, who he and his team at Imperial College performed what is the first modern trial where they compared psilocybin therapy, meaning 2 doses of moderate high dose psilocybin with psychological support. They compared that to a head-to-head comparison with escitalopram or Lexapro. Their primary outcome measure of depression didn't actually show that the two were significantly different after 6 weeks of the intervention, but they did have a number of other measures that did show that the psilocybin treatment group seemed to be doing better in terms of their depression. It's great to see more trials happening, more patients having experience with psilocybin and starting to ask some of these real world questions. If you have a patient that you want to consider, should I send them to a research study to try this, or if this is an approved medication, would I refer this versus something else? It's great to see that sort of research start to attempt to answer those questions. And again, it's not clear to me that psilocybin is necessarily an antidepressant, even though it may certainly help with depression in some patients. At the same time, something you were talking about how psilocybin might be helpful in palliative care is, people who are facing a life-threatening illness, maybe having a sort of a sense of hopelessness or a loss of meaning in life, that can be really traumatic too. And so to what extent, should we be thinking about psilocybin when combined with talk therapy as a way to treat trauma-related disorders? This is something I know that you're very familiar with, is addressing trauma. And I really appreciate the insights of one of my colleagues, Dr. Alicia Danforth, who likes to say that, any psilocybin session can become a trauma session. So how, if we're treating depression, but sort of traumatic experiences come up, psilocybin therapy needs to be able to address all that safely if we're going to ask participants and patients to undergo these experiences with us.
Yeah, so that's the importance of assessment of the patient to see what is the presenting problem, what are the symptoms, what are the conditions in which this person may have, what kind of previous experiences they might have had with altered states of consciousness, and how do we prepare them for that? And even when an experience with psilocybin or any other entheogen or hallucinogen can be very powerful, and it can induce mystical-like experiences and healing and bring about an overall sense of well-being. How is that integrated? How is that sustained? And so we already have, I think, at this point in the field, it's established that psychotherapy is a crucial and essential part of the healing, right? Because just the medicine alone, which offers tremendous potential and awakens this innate healing capacity that sometimes has been dormant, in itself is not alone. So it does need to have a whole support system around even how these medicines are taken, with a preparation before, a right setting during, and an integration after, for these to have the right effect. And for some people, it may not be the best type of treatment, right? And so my question to you now is, what are the counter indications or dangers in this kind of treatment modality? What are the risks or side effects besides a person potentially being traumatized by a journey?
Yeah, well, I mean, speaking of screening, right? That's you said it, and I totally agree. This is a key part of this is who should these treatments or these experiences not be offered to. And I think we have a fair idea. It seems like there's a fair bit of a agreement in the field about, there's some people who have pre-existing psychotic conditions, bipolar disorder, people who are in extreme states of crisis already, probably would not benefit and very likely could be harmed by going through these experiences. And we know that, for better or worse, because these medicines, these drugs like psilocybin, LSD, were given to a lot of different types of people in the mid-century. And so the guidelines that we have today were sort of found by, trial by fire. And it's great that we follow them. And yet, because a lot of the clinical trials are conservative, especially early on in a field, this is typical. There's a number of patients with particular conditions who have not been exposed to psilocybin and other compounds. And so we actually don't have that great of an idea of some of the safety parameters. In particular, again, thinking about palliative care, how sick, how frail might someone be that you wouldn't want to offer them these treatments? What types exactly of heart conditions are appropriate and not before undergoing psilocybin therapy? Are there ways to use other treatments to sort of prevent a bad outcome? I think a lot of these questions still need to be asked. And as we treat sicker and sicker patients, we will, with informed consent and doing the best job we can to make sure it's safe, start to learn some of these parameters. But, in general, I do worry about people with pre-existing heart conditions. This has been screened out of all the current studies, all the current trials. And yet we don't have a great sense that if someone had maybe like a heart attack 2 or 3 years ago, but they're doing pretty well today, how appropriate is it to give them a high dose psychedelic session? So we just don't actually have a lot of information on that.
Mm-hmm. I can't help it but just think about Stan Groff back in Maryland when he was taking the cases that, people with severe mental illness that weren't getting better with other types of psychiatric treatment, and he would take those to try out psychedelics. And so it's pretty far out what he did there. And then nowadays in the research, if a person has been diagnosed with bipolar, they are automatically not qualifying. So the inclusion and exclusion criteria for participants has changed quite a bit in these controlled trials. Any other exclusion criteria that you see? So heart conditions, bipolar, psychotic symptoms, any other exclusion criteria that you would like to mention?
Well, one thing, patients with bipolar disorder, there's at least a couple studies underway or preparation for treating patients with bipolar 2. So patients who haven't had full manic episodes in the past, but who do suffer from really severe, hard to treat depressive episodes. So that is being investigated now. And I think we'll learn more about the safety and efficacy, certainly from some initial studies. Something that you and I have talked about before, and I think is important is, again, going back to the issue of trauma, is, how do we safely work with people who have trauma histories, who maybe have dissociation as part of their condition. That, it seems like that can be very challenging and not always beneficial for people. And yet at the same time, it's a different molecule, but it was really good to see the data that just came out about MDMA and treating PTSD, severe PTSD, including people with dissociation. So some psychedelics might be more appropriate and some types of psychotherapy might be more appropriate, but thinking about classic psychedelics like psilocybin, people with severe trauma backgrounds, this may be very powerful, and it may, we may need to make modifications to the treatment protocols, maybe lower doses, maybe more sessions of psychotherapy before and after, in order to make it appropriate for people with significant trauma histories.
Mm-hmm. What are the main challenges in conducting research with psilocybin? Has people had difficult experiences? Really negative experiences? Is it difficult to set up a study? What are the challenges there?
Yeah. I think that depends a lot on when you're talking about, if we look at some of the really pioneering work that was done 20 years ago, I think there were many more hurdles as far as concern from ethics committees, difficulty with fundraising, and a real hesitation from regulatory agencies like the FDA to see this work move forward. But thanks to the careful work of people like the team at Johns Hopkins, Charlie Grob at UCLA, the team at NYU and elsewhere, this work people have been able to show proof of concept that you can do this safely, right? Which is so important here. These days, there's a real blossoming of the field with people investigating, in particular with psilocybin, its application for treating addictions, certainly mood, anxiety disorders, other things like eating disorders and OCD. And so, you can do it, but the many regulatory steps and just the real cost of conducting the research is significant. And there's always the question of, how do you train your clinical team? I think that comes up a lot. If someone wants to start doing this work and they haven't done it before, where do you get good supervision? Where do you get mentorship? Where do you get good oversight of how to train your staff to really be able to do well by the patients who are going to entrust their well-being to the investigator team? And so I think that's a real hard part, is getting a good team together who feels comfortable, especially when people are having challenging experiences, and who at least have the possibility of getting supervision and learning through these experiences in a constructive way is a really important part. And that takes just sort of really time and study and getting to know the field.
Mm-hmm. Yeah, and I'm assuming here we're talking about multidisciplinary teams, right?
Yeah.
With doctors, with psychotherapists, and with usually a whole staff to be able to support patients in this long, because usually some studies are just with one journey, some studies have more, right? But it's in any way a big holding in order to complete a treatment. And when you think about the parameters of the research, including the multidisciplinary team, sometimes two therapists in the room with the patient,
Yeah.
long hours for the sessions, a thorough assessment, a lot of psychotherapy before, during, and after, doctors, and how do you see this kind of treatment being transferable to a mainstream offering of psilocybin-assisted psychotherapy?
Yeah. Well, I mean, Gisele, I think you did a great job there just characterizing a lot of the details that we need to be very transparent about when we are reporting the outcomes of this research. Who is in the room? What is the training of the people doing this work? How many hours of psychotherapy were involved in the study? And did the investigators even call it psychotherapy? Is it enough to call it psychological support? Is that really different in nature than having trained psychotherapists who will meet with people for multiple sessions before and after? There's a lot of questions, I think, as the field we're going to be able to start to answer. How much preparation is really necessary, and for what types of patients, right? And it may be that one laboratory conducts a study and it shows that the headline might be psilocybin wasn't helpful for this condition, but it's not just psilocybin. It is psilocybin plus all of these components of a really complex behavioral intervention, that if the hours of psychotherapy before or after are different, or the clinical stance of the facilitators is rather different, that may explain things far more than the dose of the medication. And so I think we'll start teasing that out, but we'll have to pay really close attention to the types of details you just listed off.
And those details changes the results of the study, and how you understand the effects of the psilocybin. And so, because there's always the placebo, right? And so that's an interesting thing too, because some studies that you see an improvement, some of the MAP studies, of course, there's a big difference, and you really see that the people who did take the MDMA improved significantly. And they have a very thorough way of following through and looking at the results after. But some people with placebo actually get that under certain conditions of care, that includes psychotherapy, and includes a certain holding, and includes a certain way that the person can get in contact with themselves and with their trauma, they may feel better even without the medicine. And so it's an interesting paradox why we look at these medicines as being so transformative and so kind of like a beam of hope. You can also look at the other side. There's some elements that may be healing just by itself, with what gets activated for the patient. But if we're thinking about most of the clinical trials, we know that they have been focused on individual treatment, and we know that it's been very expensive to run that kind of treatment. What are the possibilities for this kind of treatment to eventually become more affordable, accessible? Do you think that at some point we'll be able to have group therapy or health insurance and things like that with psilocybin-assisted psychotherapy?
Yeah. You're touching on some really big themes. What if this gets approved and it's not really accessible to people? What if this is available, but like a lot of things in mental health and healthcare, only benefit some members of our communities? Is it really going to be transformative anymore? Certainly an issue. moving beyond questions of economics, I think, when people bring up group therapy, or at least group preparation and integration, if not also group administration of the medications, it may be important for us to get to the point where we can think about that as far as healthcare delivery and how to make it more economically affordable. But my bet is it will certainly change the intervention itself. It'll change the type of care that we can provide with psychedelic-assisted psychotherapies, because of the importance of the group, especially probably in integration. One thing I was thinking about earlier today was how so many of the studies that we have are short, as is common in biomedical research, that we don't know what the real outcome is of these treatments. Do we need to have people come back every 3 or 6 months? What is the best way to have whatever benefits people may gain, have them really endure? And something that is a sort of tried and true lesson from the communities where psychedelics have been used for a long time is that the people around you are an important part of the integration. So we were really excited to have the opportunity at UCSF in 2018 to conduct our group therapy study with psilocybin and demoralized long-term AIDS survivor men. And I think it was really powerful that the participants got to connect with each other during the study, where we had group therapy before, and as part of the preparation. All of the medication sessions were conducted individually. So the participants were by themselves with their clinicians. And then we had group therapy afterwards to integrate. And just sort of anecdotally, it was very powerful to see the participants being there for each other, hear them talk about how they were looking forward to getting through the psilocybin experiences, even when they were really challenging, in order to be part of the group and process in a group. And frankly, sometimes the experiences with psilocybin were really hard, either during the day and even sometimes for days after. People were still processing through some really challenging memories or visions or experiences that they had, and being able to receive support in a group from people who they thought were like them and had been through similar challenging experiences, or sometimes just unusual experiences, seemed to be a great comfort, especially for a group of people that are rather traditionally marginalized, gay men and rather isolated. Long-term AIDS survivors is, it's a community that was hit very hard by the epidemic, and they've lost a lot of loved ones. And so to get to see long-term survivors connect with one another and really open up emotionally, psilocybin or not, was very powerful. But certainly going through these experiences together was also, I think, a very important part of whatever benefits they may have had from the study.
Wonderful. That was a wonderful study that you were involved in. I love the aspect of the group work and that sense of community and strengthening one another and the shared space and the commonality also of experiences and the possibility of being accessible. And so I do hope that in some way you get to reproduce that in your work with UCSF, and because it's a great model.
Yeah.
And as we're talking about the clinical trials, and the MDMA for PTSD is in phase 3. We just saw the news this week, right, from MAPS, a revolutionary contribution to psychology and psychiatry. Where's the development of the research with psilocybin in this moment?
So psilocybin clinical trials, there's been a lot of small studies, so single site studies, phase 1 or early phase 2. There's currently now 2 industry funded studies, both looking at different types of depression. And there's also a psilocybin study for alcohol use disorder that finished recently. Their results hopefully will be published soon out of NYU. And then it looks like psilocybin-assisted psychotherapy for alcohol use disorder will probably be the first clinical trial that's a sort of a phase 3 for that drug. So, you know, if MDMA's first indication to go to the FDA is probably going to be severe PTSD, for psilocybin, it's likely to be a type of depression or possibly even alcohol use disorder before that.
And it's entering phase 3.
Yeah, they're planning the phase 3 trial now.
Now, last November 2020, the state of Oregon voted on Measure 109, a ballot issue known as the Oregon Psilocybin Service Act, and that approved the legalization of the use of psilocybin for adults in controlled clinical setting for treatment of mental health issues. And so they're planning the clinics in the state of Oregon. And so let's talk a little bit about that, because that is happening. And what I'm curious to hear from you is that even though this measure was an incredible conquer, both the American Psychiatric Association and the Oregon Psychiatric Physician Association opposed the measure. What are your thoughts on what's happening in Oregon with the clinics?
Well, it's very pioneering for certain. I'm not surprised that this comes out of Oregon, which has also really led the way in this country on other sort of controversial health issues like medical aid in dying or death with dignity was really pioneered in Oregon, as well as you know, the regulation of cannabis for use by adults that happened in Oregon before it even happened in California. So with Oregon legalizing psilocybin therapy, or I should say, therapy with psilocybin mushrooms, going back to what we started talking about, this is not going to be psilocybin that comes in a capsule form that's sold and approved by the FDA. It actually doesn't change anything about federal regulation of pure synthetic psilocybin as a medicinal product. But some form of psilocybin mushrooms will be available for use, like you said, in a controlled clinical setting. And, you know, I look at that as it's part of the laboratory of the United States, where states actually, states regulate medical practice and you know, medical care. The FDA regulates the interstate commerce of medical products. And if the state of Oregon chooses to legally produce forms of psilocybin mushrooms and make them available as a type of treatment, it's very innovative. It's very experimental. I don't know how the federal government is going to respond to that. They may choose to not interfere, or they may choose to interfere. The clinics might not actually happen. We'll have to see. But I do think it's a very, again, pioneering way of providing these still experimental treatments to people, patients, or people who don't have mental health diagnoses. But to do it well and to do it safely, the state of Oregon has a lot of work in front of it. It needs to define clearly how they're going to certify facilitators, think through what are going to be safe protocols. How often should people do this? Is it okay to do a treatment once a week? Should it be no more than once a month? And importantly, I think when things don't go well, what is going to be the response, not just of the Oregon Health Authority, but also the community of providers? How are they going to learn from adverse events and train people to do better and try to prevent that moving forward? A whole sort of culture of care and science of treatment needs to be developed. So Oregon has a lot of work to do, but I hope that we can learn a lot from what they do accomplish.
Yeah, it's an incredible task. So the Oregon Health Authority is going to decide and who is going to be licensed as a facilitator. They will determine qualifications, education, training, and, like you mentioned, creating a code of professional conduct for these facilitators so that hopefully people can learn from it and sustain a ethical and liable use of psilocybin. What are the essential skills that you think, and you mentioned that in relationship to the research too, what are the essential skills that you think facilitators should have when guiding people through psilocybin sessions?
Mm. Well, you mentioned interdisciplinary teams earlier, Gisele. So I think that's really important. Is the if anyone wants to take on the responsibility and onus of providing these experiences in a safe way, is first recognizing that I don't think any one sort of uh, professional group or any one sort of class of practitioners knows all the answers and knows what to do. So if anything, I would start with good communication between people of different experience levels so that we can learn from each other. And when we don't know what to do, that we know when to refer to other providers, or to get consultation when, for instance, there may be very serious medical contraindications that you're not sure if perhaps it's safe for someone to undergo this, and who do you look to for, with humility, who do you look to for guidance on whether or not to even proceed with the treatment in the first place? I would start there. um, and then something else I think, has been highlighted a lot in the field, is it's really important to be able to build trust with people as part of the preparation, to make sure that you can safely work with them and help them get through what may be beautiful, very helpful experiences, also challenging experiences, which can be helpful, but take sort of more work to get through. And if someone is present, warm, and able to build a strong connection with people before the experiences, and really ideally make the experience and the treatment about that healing connection and not just about the drug or the experience itself, that seems to be a really foundational piece. Um, Now, how do we do that, and how do we work with people of different backgrounds in different communities, is a huge question. So there's no, one practitioner that's best for everyone, and especially when people come with different needs, um, isolation, experiences of stigma, and actually, even distrust of the medical field. How do you work with people who are seeking help but maybe have a really hard time building trust in the first place? Um, Again, it comes back to, for me, a lot of it's communication, supervision, and a good ability to learn and understand that you're going to get it wrong sometimes too, is a very foundational piece.
Mhm. Yeah, so the idea of multidisciplinary team and the knowledge of the both physical and psychological effects that these medicines may bring about. Um, I, knowledge in mental health and the ability to support people through trauma,
Hmm.
being experience and diversity, and inclusion, and understanding people's walks of life and ways in which their experience has not been held right by the medical system, and how to validate that, how to have also different cultural elements represented, whether that is race or sexuality or gender identity, socioeconomics, so that people can feel like, oh, I can be myself here. I
Yeah,
can be understood here,
yeah,
right? Then we have to think also about, familiarity of the professionals with these mystical states of consciousness, their ability to cultivate equanimity and acceptance, in intense moments, in moments of change, ability to support somebody make meaning on an existential level, of what may emerge. And so there's a lot of different qualities, and we're here, representing in some way a mainstream field, you as a doctor and me as a clinician, as a mental health practitioner.
mhm.
Do you think that there's space for non-licensed clinicians and alternative healers in this field, in this idea of a multidisciplinary team?
Yeah. Well, I mean, stepping back and just thinking about, is the medical model, is treatments in medical clinical settings the only place that these types of experiences can and should happen? And I don't think so. I think there's, many traditions and use outside of medical treatment that need to be sort of respected and sort of revered for, the knowledge that they have. I just want to start by saying that, to be focused on this question of, if these are medical treatments, particularly like in the United States, if these are medical treatments, what is the role of people of different levels of credentials? Certainly having a medical degree, graduate training in psychotherapy I think could probably be very helpful, but is definitely not sufficient, and is not always necessarily the best training. I can share briefly, there was one clinical trial treating patients with a mental health condition, and a investigator who was sitting for participants in that study, so that there was a psychiatrist sitting with him, and the reaction of the patient to the psychedelic that they took in the trial was so unusual, so different from what the psychiatrist was used to. They literally got up and said that they could not stay, and they walked out of the room and made a comment about how they were not trained to deal with these types of responses. And so, it's, again, comes back to, who's the team? How comfortable do they feel with the unusual responses, or the maybe unusual for mainstream mental health, but actually are pretty usual and not, abnormal or bad for psychedelic responses and experiences. And how do we get people comfortable being able to support the person for whatever they're going through, respecting what they're going through, their process, and support them, even if it's not something that you yourself have experienced. Even if the clinician has either had or not had psychedelic experiences, you may sit for someone who is undergoing something very, very different from what is, your usual frame of reference. And how do you make it about them, and making sure that they feel safe and supported throughout? That's, I think, a lot of people would agree is pretty fundamental.
Yeah, but I can't help it but to make the point. Don't you think it is important for people who will be holding space to be familiar with those states themselves? In other words, the question is, are people interested in working in the field of psychedelic-assisted psychotherapy? Should they themselves have experience personally with altered states of consciousness?
I think the way you put it is important, having experience with altered states of consciousness. Whether or not someone has ever taken a psychedelic, there seems to be things about different states of mind and the body that can be reached perhaps through meditation and other sort of very intensive focused practices that are likely helpful for preparing people to sit for others. I don't personally say that it should be a requirement that someone has prior experience with psychedelics in order to sit for someone. But again, this is where, who's the co-facilitator in the room, if there is someone, what's that person's experience? And I think these can be empiric questions that we can assess with time. I mean, who seems to be a better guide? Is it someone who's had many sessions themselves? And if you haven't had many experiences or any, are you able to listen to people who have and learn from them about how to do this in a really safe and appropriate way? I'll say personally, before I was even a physician and I was doing participant observation based research, and I had gotten to become friends with people who were participants in ayahuasca churches that were, legally drinking ayahuasca as a sacrament in different settings. It was very profound for me to learn from people with a lot of life experience, working with these substances. And I personally also, I drank ayahuasca. I've had those experiences. It's very informative for me to reflect on how, what it might mean for someone to go through an experience like this, and how, not making it about me, but making it about how can I, if I'm a clinician, be as supportive and helpful as I can. My prior experiences were helpful for me in those reflections. And so I think it's important that people have those opportunities in ways that are safe and appropriate, if they are going to take on the responsibility that comes with being a facilitator.
Yes. So this leads us into, you know, alongside research, alongside medicalization of psychedelics, alongside the measure in Oregon is the other one is that instead of measure 109, it's 110, right? The decriminalization of possession and personal use of drugs. And so we know that is very important from a social political standpoint because of the war on drugs, because of mass incarceration and racism in this country, and how a lot of people have not been able to use their own medicines, and have been persecuted and put in prison because of that. So we know Denver became the first city to decriminalize psilocybin mushrooms in 2019, and then Massachusetts, Oakland, Santa Cruz, Ann Arbor, Washington, D.C. How about California? You know, where are the efforts to decriminalize psychedelic plants here?
Yeah. So, right now in the California legislature, there is a bill that's being considered to decriminalize or make lawful the possession and use of psychedelic substances, including in small group settings. It's not a piece of legislation that would authorize the sale and distribution of psychedelics, but it would make it no longer punishable as a criminal offense to possess and use. I think there's, as you're saying, a lot more recognition that many people in this country feel that it's not right to put people in jail or to incarcerate people for using substances. We should treat these things as health issues, public health issues, and address them accordingly, and also think about them as sort of larger social issues, like you're bringing up, like what are the costs of incarceration of particular communities that have suffered so much because of drug laws. So in California, it's interesting that there's interest of decriminalizing lots of different types of drug use, making, for instance, there's been an attempt to make safe injection sites available, not for psychedelics, but for other substances in order to take a harm reduction approach to public health. But also for psychedelics, there is a push to follow in the steps of some other cities, like our right here in Oakland, California. We've had decriminalized psychedelics actually for some time now, thanks to the local efforts of a number of people who worked really hard to make that happen with the Oakland City Council. And we may follow at a state level. But if we do, again, all these issues of training, supervision, learning, and again, safety, all the safety around this is going to become far more important if many people feel that they might want to start doing this, or they become interested in learning more about it. We're going to need a lot more education about how to do this safely if it can be safe, and it's not probably safe for everyone, which we should be talking about.
Mm-hmm. Yeah, sometimes I like to look at examples in other places in the world and how they're doing it, and so Portugal shows up as an example, the Netherlands, Austria and Jamaica, where psilocybin is legal. And in Portugal specifically, when they really decriminalized all the drugs, there was excellent results. You had overdose was less, prison overcrowding was less, addiction rates fell, and cases of disease related to drug injection also dramatically fell. So they had like an overall, including, so people becoming less addicted, and so they had a very positive results overall. The only thing is that they had more homicides because the gangs thought it was all free for all, and there was a lot of encounters with the police. But other than that, on a social level and on a health level, it was better in every aspect. So it's something for us to see how much the society would hold, and how much the ethics and the therapeutics would come together if the decriminalization, passes, and people are allowed to then, design ways in which people can explore this safely.
Yeah, I mean, I think part of the success in Portugal was also really making available social services and health services for people
Yes.
who did have, sometimes issues with using substances in ways that were not healthy or very helpful for them. And, and that I think comes back to this issue of, so what are the structures that come into place, and
Yes.
I think I always come back to this reference that in my life is, Brazil, and how they've treated ayahuasca churches there, and, announcing that they were going to be allowed to function as part of the cultural patrimony of Brazil, going back many years, initially starting in the 80s, and then sort of that being ratified more around 2010. And it's not just that, anyone goes and just makes ayahuasca wherever they want and they drink it whenever they want. There's a very strong culture of ritual and respect of tradition and teachings, and having oversight. And I think it's incredibly powerful to think about how communities can organize around responsible, safe, very respectful use. And the communities can hold their own members accountable and make sure that within themselves, without the intervention of medical professionals, without the intervention of legal sanctions, that they enforce their own standards of safe practice. This is a very powerful way for us to think about what can be appropriate for substance use. And, I'm curious to see what types of traditions and social norms and social controls, can be created or already have been created in the United States that we're going to start to learn more about as as decriminalization and regulations happen more and more in this country with psychedelics, and potentially open up new possible forms of cultural forms and ways of making this hopefully safe for use here.
Mm-hmm. Yeah, well said. So the larger structures, like you mentioned with Portugal, it's true. There's social services and programs and therapy and all of that. And as well as the example from Brazil of communities and a connection to land and to culture, and to community. And so there is an accountability and there is a support there. And it's accessible and available to everybody who wishes to partake in that. So we're coming kind of to the end of our time today. Soon I'm going to move over to the questions of the audience. But for you personally, what have been some of the major influences that led you to this work?
I started, learning about psychedelics and wanting to research them, years and years ago, before it was much of a field, and actually when many of my mentors warned me that it was a very hard field to be in, or didn't really even exist yet. And many people at that time were discouraging young people like myself from even getting involved. But I found it very compelling for the reason that, as a number of people have said in this field, that psychedelics seem to be, compared to other forms of treatment that we have at least in modern medicine today, they seem to be meaning-making medicines. They seem to be interventions that help people find meaning and purpose, or at least that leave people with the sensation that they've been in touch with something very meaningful, even if, as I think we know, sometimes after psychedelic experiences, it might be hard to articulate what exactly that meaningful piece of information or that insight was. But the experience of being in touch with something very profound, something that seemed to happen sometimes over and over again with psychedelics. And for me, that's something that, either through my work in social sciences and anthropology, or as a psychiatrist working with patients, something about helping people find meaning in their life and in their experiences is such a fundamental, I think, need of people. I mean, Viktor Frankl said this, many people in humanistic psychology have said this, and I don't know of too many other interventions that can so powerfully and potently give people an experience of really intense meaning. And so for me, that underlies it, and also underlies my interest in things like demoralization and people finding meaning and purpose when they struggle with significant illness is I think this is a great tool for potentially addressing a lack of meaning in life and hopelessness. And I really hope I would feel very fortunate to get to continue doing this work and see how reliably and safely we can use these tools to help people find meaning again.
Mm-hmm. And you're currently connected at UCSF. I know that they're bringing some special people over from Europe, but I also know that you're going to be connected to a center here in Berkeley. So what is your vision for your work? Where are you going? What's coming in terms of your own manifestation and your vision for this work?
So yeah, at UCSF, there's a number of investigators. There's a really rich community here of people studying psychedelics, both to look at sort of the mechanisms of how they maybe work in the brain, but also how they can be used as treatments. It's exciting to be part of that community, but also being affiliated with the new center at the University of California, Berkeley, the Center for the Science of Psychedelics. It's been a really awesome opportunity to get to work with an interdisciplinary group of researchers to think through how this center could be used for conducting human research in this area. Also doing what I think is really important is the sort of public education around these substances and the potential impact of the research, as well as working with colleagues in different schools at UC Berkeley and at the neighboring institute, the Graduate Theological Union, to think about how we can do really good training for becoming a facilitator and providing these experiences for a diverse set of people, whether they be patients or just sort of healthy volunteers in research, or even religious and spiritual care professionals. It's been very rich to see a strong interest from Berkeley and GTU and people elsewhere in thinking through how these core elements of this work, research, training, and education, can all come together. So I'm excited to see what we're going to be able to do there as well.
Fantastic. Well, it sounds like a wonderful project. And when do you think that will come into manifestation, into fruition?
Well, the UC Berkeley Center launched last year, and we hope to start our research studies early in 2022. So look out for that.
All right. And so moving here over to the questions of the audience. So Patrice Jones asks, what factors ensure a healing outcome with psilocybin? Is it the intention, the environment, the reflective practices, or a combination?
Great question. I mean, we touched on some of that. I mean, I would say that when so far in clinical studies, there's always been a combination of these things of making sure that we do help people find some intention, that they're coming to this with a real purpose. They're not just trying to see what can happen or just have some fun. They're really trying to work on issues in their life. Having a safe, supportive environment is just key. I wouldn't do this work without really spending time and care setting up the setting for the study. And then, as we've talked about, making sure that people continue to work on whatever comes up for them in the experience, ideally in a sort of psychotherapeutic setting, if this is a mental health treatment study. When you look at the studies kind of overall, it does seem to be important also, just like the quality of the experience itself, in particular how intense or strong it is. If someone has more of a mystical type or transcendent type experience, it seems that may correlate with some patient populations with having a a more notable outcome. And so, attending to what really happens on the day and how do we get patients to that particular type of experience seems to be rather important too.
Yeah. And another question, actually, a lot of people in the audience wants to understand more why the synthetic psilocybin is used in the studies rather than the naturally occurring mushrooms.
So the clinical trials are all done according to FDA regulations. And what's interesting is that the FDA does allow for natural products, botanical medicines to be studied and sold in this country as prescription medicines. It's just much more complicated to take a natural product, meaning like a plant or a fungus that you would grow and then make it into a standardized pill or a solution that you would drink, just chemically much more complicated. And so I think it's just not done very often. Feasibly, someone could take psilocybe mushrooms, grow them, and then make them into a medication that were tested in trials. It just, I think it'd be a lot more complicated and expensive. And so far, using one standard version of synthetic psilocybin is what almost all of the investigators have done over the last several decades.
And another question from the audience, they would love to hear more about microdosing and how it's being used inside and outside of clinical settings, and any general comments on this application.
I'm really not that much of an expert on microdosing myself. I'm definitely more attentive to the macrodosing and how we can use that to support patients. But in general, microdosing, this idea that sort of very, very small and more frequent dosing of psychedelics may have benefits for mood, anxiety, concentration, is something that is being studied. There are a few small laboratory studies and lots of more observational data that's being produced. Though in general, I haven't seen anything that's all that convincing that it's that much, that you could really test it in a way and find it to be that much different from like a placebo effect. But I'm, curious to learn more. Gisele, I don't know if that's something maybe you've, learned a little bit more about.
Yeah, it's hard to study because it's very subjective. And so when we're speaking about microdosing, we're talking about subperceptual doses, right? So it's a dose that the person takes a little bit, and they can drive, they can go to work, they can write papers, they can cook, they can do whatever daily activities that they would be involved in. And so it's a very subtle effect, and it works more in the chemistry of the brain and in an overall lift. And usually when combined with psychotherapy or with somebody who is really interested in documenting how they're feeling, it's almost like a personal study. So a person may engage in a microdosing and take very small doses, like subperceptual, like I say. They're not in an altered state of consciousness. And with intervals, it's usually not done on a daily basis like another type of medication. It has intervals, and so that the body can naturally also produce those effects and those chemical alterations with the assistance of the psilocybin. But it is something that hasn't been studied in the long term, and the reports on that are subjective. Very, it's based on personal reports. But some of those are happening in combination with psychotherapy, with people who want to move away from medication, from SSRIs, and are trying a different type of regimen. But it is one that requires more discipline, because one would have to be noticing, how one feels, and really document that to be able to determine whether or not it is effective in the sense of substituting an SSRI, meaning an antidepressant or an anti-anxiety medication. So that's what I would say about that. Other questions. how are the participants found for research? And could I find a study to participate in?
Um, whenever people ask, how do I find a clinical trial like this, I always say to go to a website called clinicaltrials.gov, so .gov, and this is run by the U.S. government, and it is a central registry of ideally all clinical trials that are running in the United States as well as in some other countries. But you can search for different conditions, like for depression or anxiety. You can search for different types of treatments, be that an SSRI, or in this case, psilocybin, or you can search LSD. And that's probably the best way to find trials that are near you or actively seeking participants. And that, yeah, it's pretty comprehensive. But this question is an important one for the research, is not just for people who are looking for studies. A lot of the trials so far have included participants who sought out psychedelic treatment. It's not necessarily just from a clinical provider thinking it might be beneficial for their patient and then referring the patient, but it's people who are actively seeking out psychedelics. And so it does raise a question of the information we have from these studies. How generalizable is it? Does it tell us about people who are not necessarily, fans of psychedelics or interested in psychedelics? What type of work we need to do to prepare them for these experiences? And, if people are hesitant or more anxious, might they have different results than people who maybe sometimes even like travel to another state to be in one of these trials? That shows a lot of motivation and maybe a particular type of patient whose data we are then looking at in the study.
Yeah, that does influence the results, right? Because you have a highly motivated patient that already has a preconceived idea of the outcome that treatment will produce and favors that. And so that has to be considered. Yeah, the other question here is, they want to know, and this coming from Jane, how does the psilocybin work? Meaning, what does it actually do to the brain that results in all of these phenomenal experiences?
I wish I knew. Just like I wish I had a really good answer for how does even SSRIs work on the brain to help with depression and anxiety. But we do have some idea. We know that psilocybin, like other classic psychedelics like LSD, mescaline, DMT, they do have an effect on the serotonin 2A receptor. So they seem to stimulate or they work as agonists at that receptor, and that is a common biological target of this whole class of drugs. How that affects the brain, different parts of the brain, and how the different parts of the brain kind of talk to each other because of that is something that is being actively investigated now. One thing that I think is interesting, it's not so much about the neurobiology of these experiences, but it may be sort of the phenomenology of these experiences, is that when people ask me sort of, how do you describe the effects? Or if I have to maybe tell a patient or a research participant who's maybe never had a psychedelic before, and I'm trying to give them informed consent before they decide whether or not they even want to be in one of these studies, I talk to them about how taking a psychedelic can be akin to having a very vivid dream, but while you're awake, sort of memories, visions, feelings sort of like you're in another place or that unusual things are happening. That is part of the experience for many people. And it seems that there's something about that sort of connecting with different parts of your mind, or having, your brain work in a different way that helps you connect or be in touch with these sensations and experience seems to be a key part of this. And then, of course, like we've talked about, then what do you do with that? Is it the follow-up psychotherapy, and how does that work to help have you have beneficial effects over time, not just maybe for a few days, but maybe, weeks to months, what you do with that also seems rather important.
Mhm. Next question here. Are there any studies that the use of psilocybin can trigger mental health issues that were dormant in the patient?
Hmm. There's definitely been studies looking at people who have had adverse reactions to psychedelics. There's many cases that have been published of people who have had to been treated in emergency rooms or have been hospitalized, psychiatrically hospitalized because of using psychedelics. What's really interesting and really promising is that in the modern clinical trials with psilocybin, and as far as I'm aware, other psychedelics like MDMA and LSD, or well, I'm not going to say about MDMA because I think there have been some issues with like suicidality that have come up with that drug in some studies. But with psilocybin in particular, there have been no serious adverse reactions, meaning in the clinical trials, no one has taken the drug and then have been hospitalized, had a death, or had some sort of like serious injury because of the treatment. So of the hundreds to the few couple thousand people that have been exposed to psilocybin in clinical trials over the last several decades, that's pretty promising that it shows that we have procedures in place that with good screening and good care, we can safely administer even high doses of this drug without causing harm in the trials itself.
Mm-hmm. And, for some reason, I'm just thinking here about some of the retreat centers. Some people who are interested um, in the experience and want the experience to be well held. In some places that is legal, there are retreat centers that are medically staffed, and I'm thinking about the Synthesis Institute in the Netherlands, for example. It's something of a certain socioeconomics range, because it's not cheap, but it's accessible, and it's held within a very safe and supportive environment. And there are others like that around places where that is legal. And so, in those situations, I'm sure they haven't had any strong adversary, effects, because the places are up and running, and people go there and seem to be having a good experience. The other question here is, can you offer examples of how communities launched efforts to decriminalize and or legalize psychedelics? In other words, do you have ideas on how to start such a movement in a more politically conservative environment? And what kinds of talking points or data can begin to foster understanding and compassion and bridge gaps? So probably somebody who doesn't live in the Bay Area.
Got it. There are a number of organizations that have come together that are very readily sharing their experience of how they've successfully changed local laws. So I know that the group out of Washington, D.C. That was able to pass decriminalization, they have educational efforts. Some of the folks out of Oakland through the decriminalized nature movement, they've done a lot of education for people elsewhere. And there's also an effort amongst some advocates, like those who were successful in Oregon, to try to help spread those models to other parts of the country. So I'm not involved in these policy change efforts myself, but there's certainly a number of places you can reach out and find, including Spore in Denver, right? It's the first city to decriminalize psilocybin mushrooms. You can reach out to them to ask about ways to do community education and organizing.
Mm-hmm. Another question. Uh, what effects does psilocybin have on brains in different life stages? So adolescent, young adult, older adult, and does it have and has a minimal age been identified by the scientific community?
Um, so as far as I'm aware, there's not a good answer to that last question. All the recent research has been done in adults. There definitely was a number of studies that were conducted in children and adolescents with LSD and other psychedelics in the I think in the 50s and 60s. I'm less familiar with that literature. I guess there's always the concern that using very powerful substances in youths could have a different effect because their brains are still growing and developing, and there's just not a lot of information out there. And yet there is, it's not scientific data, but there is wisdom and traditions from some communities, such as you know communities that traditionally use peyote, that have given peyote and special rituals to children and youths. Also the use of ayahuasca and sometimes children and more often adolescents is practiced in various places throughout Latin America. But this is my understanding is it's often not done in a very regular basis. It's done in more special situations. And so I don't think there's really scientific data to guide that, but there are some sort of communities of practice that may have things to say about that and teach about that.
Yeah, and what I would say about that is that in certain cultural and contexts, like you're mentioning, the peyote and ayahuasca, usually when children or adolescents are present, they're also not taking a high dose. It's usually a little taste, and so that there is a current of an energy field of a certain healing work that's being done by a family member. Those works involve a lot of prayer and ritual, and there's usually a meaning and a reason why people gather to pray. And if there is children or adolescents involved, they're just part of that healing and the community, and they're not there necessarily to have an out of state, an altered state of consciousness experience, but rather a taste of the medicine to be part of that healing field that the community is involved in. And so that's a very different cultural context. Yeah, so I just want to mention that. And the other question here by Christina: what is considered high dose psilocybin?
So there's different definitions out there. Some people would refer to the 25 milligram dose that's used a lot in studies these days as high dose. It certainly can have very strong effects. Some investigators might call that sort of like moderate high. I think of closer to 30 milligrams and studies that have looked at higher. For me, that's like what I would typically call like a high dose. But there's something about that range between 20 and 30 milligrams that a lot of studies have looked at that range to see its effects on healthy volunteers and patients. And so most studies have been sort of in that area. And it seems to be that is a range of doses that seems to have a potent effect on research participants that we think can be manageable and has been shown to be pretty safe to administer, and seems to have potential clinical benefits for patients. So something in that dose of 20 to in that range of 20 to 30 is what often has been studied. And for me, something closer to 30 and up, I would consider certainly to be high. But for some people, 22 milligrams might be a very strong dose and might be a very strong experience. And so it does seem to be pretty dependent on the person.
Yeah, and let's just be clear here that Brian is talking about psilocybin compound and not mushrooms, because if somebody asking this question and let's say they watch the film The Fantastic Fungi, and they're thinking about Terence McKenna, or they're thinking about Paul Stamets, or they're thinking about Rolf Metzner, and what those guys would consider a high dose, and then it's the pure mushroom, and then there's different ways of looking at that, right? And so that this amount does not mean mushrooms, it means psilocybin.
Exactly. I'm just referring to the clinical trials that have used synthetic psilocybin, and depending on different types of mushrooms and how they're grown, the amount of psilocybin and other compounds in them might be very different. I really don't encourage people to try to translate milligrams from the study into dry or fresh mushrooms and then try to replicate that. Again, it's also, I think, sort of a mistake to try to replicate what's done in the scientific work based off of just a dose of a substance, because all of the preparation and the screening and everything else that goes into trying to do that in a really safe and careful way, that's really important too. And again, it's not just the substance.
Mm-hmm. And the other question here, Alex asks, what degree or credentials would you recommend for a young person looking to enter the field of psychedelic-assisted therapy facilitator? PsyD, MSW, licensed marriage and family therapist, LPCC, advanced nursing, or non-clinical pathways? Are there any specific institutions or programs you recommend, either in the US or internationally? So I'll chip in there. I will say, if you're a young person looking to enter the field, I would recommend a clinical degree, either in psychology, in nursing, in medicine. I do recommend the institute, the California Institute of Integral Studies, as we have many master's degrees, programs, PhD, PsyD, and we also have a center for psychedelic research and therapies, that it's a postgraduate program. There are other institutions, and as for a master's degree, you could take it at any university and then do a post certificate at CIIS, or MAPS is also another institution that trains people. Who else would you recommend, Brian?
I think, Gisele, a big picture consideration here is that if people want to do clinical work in this field, it's really important to be grounded and to sort of have a strong degree of sense of why you're doing this. I think it's actually very helpful for people to not only try to do this. So if you want to go get a clinical license, I would choose a clinical field that you would be happy doing that work, even if you weren't involved with psychedelics, and maybe to try to involve some clinical work that's not just psychedelics in your practice, to have a little bit of balance. I don't know too many people that have a career only doing this work. And I know many people who've tried to only work with psychedelics, and it can be challenging and they can get a little burnt out. And so if you're going to go down a career path, if you're going to go through licensure and all of that, choose something that you would be happy doing, even if it didn't involve psychedelics, and it probably is a more sustainable path for you.
Yeah, well said. Very well said. Thank you, Brian, so much. It's been wonderful to talk to you tonight, and I hope that the audience received a lot of good information and feel stimulated by your presence here with us today. Do you have any final comments, anything else that you wish to say before we end our time together?
Thanks. Well, thanks for having me, Gisele. It's a pleasure to get to chat with you. And I'll just say, this is a very exciting time for the field. It seems like a lot is happening, and a lot new sort of endeavors with psychedelic medicines are coming forward. And this is just a really small tip of the iceberg. All the medical research and the focus on and companies and science, I really feel is a very sort of pale comparison to a lot of knowledge that's been in the different communities that have used these substances for generations, if not centuries. And it's good for us to keep that in mind and keep some humility about this work, it's very exciting, and it's very promising. And yet at the same time, people like myself who do research, we're just beginning to learn about this field. And I think we should keep that in mind, and think about the people who came before us in the communities that still do this work and probably will do it, for many generations to come.
Mhm. Thank you. Wonderful. On that note, I will invite Jason back.
Thank you all so much for attending today. We hope that you will join us for more of our upcoming talks and workshops. This conversation was recorded. If you'd like to watch it again or share it with the community, it will be available on our YouTube channel at the same link and on our Facebook page. We will also feature this talk on our podcast, which you can find at CIISpod.com or by searching CIIS Public Programs on your favorite podcast app. Thanks again for joining us, and good night.